Welcome, everyone, to Dr. Kris, the Resurge Clinic. How are you doing, Dr. Kris?
Good, Steve. How's your day going?
Going pretty good. I had a big live stream earlier today, and now I was looking forward to this one, even though our topic is somewhat sobering. Today, we're going to talk about Alzheimer's. And Dr. Kris is going to do a presentation about this. He's got a lot of experience in it. He works with a lot of folks that suffer from this, and I'm looking forward to learning some more. So, Dr. Kris, how did you let's get a little backstory right quick before we start on this. How did you actually start to wander into this area?
Well, so this started quite a few years ago, and it actually, some of my patients know this, some of my patients don't, that I've had a long, extensive career in actually skilled nursing facilities, or you might know them as nursing homes. And as a family practitioner, I got asked about 12 years ago to start helping out at one of the local skilled facilities, and I thought, oh my God, I never wanted to do that. And then they talked me into it, and I actually started to really enjoy it. And of course, in my facilities, one of the major conditions that a lot of the patients have is Alzheimer's dementia. And I've been over a actual secure memory unit for probably a decade now. So those are going to be your end stage Alzheimer's patients that, maybe they exit seek, or they're usually oriented times 0 to 1 to self only. Sometimes they don't even know who their families are. And and then also just, I think that nearly everyone's had some sort of a personal experience in their life with Alzheimer's, whether it's a loved one or a relative, or, a loved one or just a good friend. It's just very rare that you meet anyone of any form of age that has actually not been affected in some way by dementia one-on-one.
It's certainly impacted my life, and it's just this ugly, evil disease that takes away. I think the thing that really shocked me was when I realized that my loved one didn't remember my name.
Yeah, could you ever imagine one point in your life that you won't know who your brothers or sisters or your wife or your kids are? I mean, or your grandkids maybe at that point. It's just, I tell my patients all the time that I think I would probably rather deal with nearly any illness versus dementia, because the patient at some point most likely is going to lose all grip with reality, and then the family's left to kind of deal with the consequences of that. I many times tell my family members that, your loved one has pretty much left, but the body can be left behind for a very long period of time. Sometimes I have patients or families say, how much longer can she live like this? And unfortunately, they can live a really long time like that. And that's the really sad part. And we're starting to learn a little bit more about Alzheimer's and dementia in general, and starting to get better treatments for these things. But still, we have a long ways to go when it comes to dementia. I still think the best route for dementia is preventing it, because the treatment options, although we're going to talk about one in particular here in a second, they're still not stellar. We still got a long ways to go. And I think that's where, and one thing we wanted to discuss today, and I'll just go ahead and discuss it now, is we're really excited about a test that we've been exposed to that we should have access to in the next 90 days. And it's a test out of the UK. It's called Cytox, and it's a saliva-based test that actually looks at 100,000 different markers for a patient for a reasonably affordable price, actually, to really give you a real-time risk factor for developing Alzheimer's dementia down the road. And I think that's going to be invaluable in our practice. I have so many patients that are concerned about dementia. And, if you know you're moderate risk or high risk for developing it, I think that's going to really be impactful in the fact that you'll be able to really do the things that you need to lower your chances of dementia down the road.
Yeah, so I'm looking forward to this. Why don't you go ahead and kind of run us through this, and then I've got a lot of questions.
Yeah, so we're lucky enough that we're actually doing this lecture nationally on Saturday. We got asked, along with some of my esteemed colleagues, to do little 20 to 30-minute lectures on individual topics this Saturday. So this is just a preview. We're kind of doing a run through to see how everything works today. So we're specifically going to be talking about the peptide GHRP, growth hormone releasing peptide. So let's see if we can make this work here.
Make this smaller. There you go. No, yeah, that one.
We're working on sharing our screen. This technology, they update it all the time. So you always kind of cross your fingers when you want to.
Well, I just hit share, Steve. Did it work on your side or no?
Not on my side. So did you send it to me? Is that?
Yeah, I did email it to you. See if
Okay,
you may
cool.
have it on your side.
So if you want to go ahead, I'll get this pulled up.
Okay. So the talk that we're doing on Saturday is actually sponsored by the Alzheimer's Foundation of America, and they're a really awesome research group for Alzheimer's. What I really like about them is you can actually donate to them, and actually you can designate how you want your money spent and what form of research, which I think is really, really cool.
Let me get the right one.
I'll wait till you pull it up. But anyway, it's really cool. I thought that was a really unique thing, that you can actually pick different areas of research and how you want your money spent. The lecture series on Saturday is absolutely free. Of course, we're hoping people see value in it and donate a little bit to the foundation.
Hang on here. That's the docs. I apologize. 1 second. We're going to get this. We're going to do this.
We'll make it work one way or the other, right?
Yeah. Okay, here it is. So, open. Here we go. Yay.
Hey, there we are. Look at that. The slides have shown up. So anyway, you can go ahead and go to the next slide. I think everybody probably listening to this knows who I am. And so anyway, the lecture again is about GHRP, growth hormone releasing peptides. And Steve, we've talked a lot about GHRPs. Many times we use most of the time we actually use GHRPs in combination with GHRHs. So growth hormone releasing hormone, growth hormone releasing peptide. And of course, the most common one that you and I talk about quite frequently is CJC 1295 and ipamorelin. And so, Alzheimer's disease is mainly dysfunction of the hippocampus, as you can kind of see highlighted in this picture here in the orange. And that hippocampus is deep in the temporal lobe, and it's extremely important in our overall memory. And so dysfunction in this area is what causes Alzheimer's disease. I'm going to have the next slide. And so the agenda is just kind of what is a GHRP, how does it work, and what kind of an effect do we think that it can have on Alzheimer's disease in a positive way. And so the first thing I always say is GHRPs, what do they do? GHRPs, and we'll get to a slide in a second that talks about it more, but we're trying to elevate growth hormone levels. So I started off with basically what can affect, what lowers or inhibits growth hormone secretion. And you got it on the right slide there, Steve. It's good. And so whenever I started putting this together, I started thinking about all of my patients in the memory care unit, and these are my patients. All these symptoms of growth hormone, loss of growth hormone, or inhibition of secretion. You talk about elevation of blood sugars and fatty acids, so diabetes, chronic illness, aging, of course. Just as we get older, we lose the ability to make as much growth hormone, obesity. I mean, unfortunately, so many of my patients are overweight, high cortisol, hypogonadism, low hormone levels, hypothyroidism. Again, I feel like every patient I admit that's in this scenario in these memory care units, they fit all of these boxes. Poor sleep cycles. I mean, anybody that has, dementia, the loved ones will tell you their sleep cycles just all over the place. I mean, they sundown, when the sun starts going down, they get rowdy. And it causes a big problem for the caretakers. And that's why many times with Alzheimer's disease, the caretakers end up in just as bad a condition as the Alzheimer's patients, because they have no set schedule or pattern, and they're trying to take care of these patients. And of course, we also have a hormone called somatostatin, growth hormone, and GHIH, growth hormone and inhibition hormone, that also can stop growth hormone secretion. So I just thought it was really important to include this slide and show like some of those things that we can do for prevention of Alzheimer's. Well, we can take care of our health. We can stay healthy. We can't stop aging, but we can age more gracefully. We can stay in shape. We can not get too much fat. We can keep our hormones balanced. We can keep our stress levels down as best we can. And I know that, we're always harping on our patients about sleep. Sleep is just so important. We actually learned recently that nighttime shift workers, shift work itself is actually now considered a carcinogen because of the overall effects it has on your body. Go ahead and give me the next slide if you don't mind, Steve.
Mm-hmm.
So what is a GHRP? Again, stands for growth hormone releasing peptide. It's produced in the hypothalamus, and we mainly know it better as a growth hormone secretagogue. So most of my patients always know me talking about growth hormone secretagogues. And as I tell my patients, we're trying to stimulate the anterior pituitary gland to naturally release the growth hormone, which is totally different than exogenous growth hormone usage, where you're just injecting growth hormone. So with the GHRP, we're causing the body to make more and release more natural growth hormone. Now, typically, as we said, we like to use it in combination with a GHRH. The most common GHRH, tesamorelin, or CJC 1295. It has a nice synergistic effect along with the GHRH peptide, but it can do a lot of benefit all on its own. It increases growth hormone and IGF-1 production, whether you use the GHRH or not. It also helps inhibit that somatostatin, which you can kind of think of that as a natural negative feedback mechanism on the GHRH. So that's why it works. That's why your GHRHs work much better when you use it with a GHRP. Next slide. So if we were to use a GHRP, what are some things that we can do? Well, I'd already one of the things also we didn't really talk about with those patients that have dementia is they actually many times also suffer from sarcopenia or even cachexia, which is a loss of muscle mass, and cachexia is just, the severity of it, a severe case. But we can see that GHRPs can reduce anxiety, depression. They help with bone density and growth. What is one of the other things that is one of the big issues as we age and with our dementia patients? Fall and fracture. So we can help with that. We talked about the disruption in the sleep cycle, and we're able to help GHRPs help tremendously with that circadian rhythm and just overall healing. From our discussions before, we know that we just talk about wellness and cellular efficiency, and how if our cells are more efficient and they have better redox, better that balance of ADP and ATP and NAD and ADH and so on, we just get better. Our overall health is better. And so with GHRPs, they absolutely have that ability. And then getting back to those ones that have that sarcopenia, loss of muscle mass, one of the most common reasons that our Alzheimer's patients die is either fall and fracture or they quit eating. They just flat out don't eat, and they start losing their muscle mass, and eventually they lose their ability to fight on. And so GHRPs can help with that as well. Next slide. So, as maybe some of my patients get tired of hearing, we're always harping on them about cellular efficiency. And the thought process there is any condition. I don't, name any disease, any condition. And if we can make their cells more efficient, we make them healthier. And it really does come down to being something quite that simple. If our trillions of cells are working and communicating more better, my West Texas accent kicked in there for a second. If they communicate better and you have better energy sources and everything's in proper ratios, the condition has no choice but to do better than it was. And we see on the GHRPs that a lot of this effect with cellular efficiency occurs with two receptors, the CD36 receptor and the growth hormone secretagogue receptor 1A, GHSR1A. And we'll see a slide in just a second that talks about that. But in addition to that, GHRPs, and this is all cellular efficiency, they increase beta oxidation of fatty acids, which is energy related. They increase AMPK, TFAM, PGC1 alpha. They increase PPAR gamma. PPAR gamma, it has an anti-inflammatory type effect on our cells. PGC1 alpha actually uses TFAM and AMPK to promote mitochondrial biogenesis, basically making more power plant cells in our, overall, so that we have more energy and better ability of our cellular function. It helps optimize the NAD/NADH ratio, which all goes back to that cellular redox that we talk about so much. We want those proper values of NAD, NADH, ADP, ATP, and so on. And it also helps optimize the TCA cycle. Some people call it the Krebs cycle, and that's our energy source. And so it does all of these different things to help with the cellular efficiency. But going back to the, absolutely, that's what I was about to ask you to do. Going back to those cell receptors, and this slide's a little bit small, but you can see how CD36 works through PPAR gamma to actually cause an antifibrosis. And fibrosis is actually the end effect of cellular senescence. And again, for our patients out there, cellular senescence are those zombie-like cells that basically aren't doing their job properly. And so we know that the end effect is fibrosis, and fibrosis is cellular scarring. We don't want that, causing dysfunction. And so that's one of the positive effects of the GHRPs. We also can see that the GHRPs through the GHSR1A receptor have an anti-inflammatory effect. They also they reduce the glial cells, which are your cells in your brain. They decrease the inflammation of those, and causing overall less inflammation in the brain. And we know that inflammation in the brain is one of the causes of this dementia that we're talking about. Next slide.
Can you see it?
No, it's still, there we go. So we know that GHRP, and what is a GHRP? There's a few different ones. From our discussions, we've always talked about ipamorelin mainly. There's also GHRP2, GHRP6, MK677, and hexarelin. And they all promote memory and learning and positive behavioral effects. So they have a positive effect on that hippocampus. And this was a study done in 2018 just showing the effects on the actual hippocampus. And they showed that there was neuroprotection from that. There was a neuromodulatory response on the hippocampus, actually. And this mainly occurs through that GHSR receptor that we just talked about on the prior page. And we know that the better we can get the GHRP levels, we improve the circuitry of the brain, and we slow down the degeneration process in the brain as well. Next slide. So I was really encouraged to see that over this was just over I think a 6-year period of time, there was 10 different major studies that we saw that totally just different studies showing all the positive benefits of a GHRP on the brain. Just study after study, I was just blown away by all the data out there showing how GHRPs can absolutely be used as a positive tool in the treatment of Alzheimer's, although we don't really see that mainstream. But there's, I just had listed out studies just showing how many studies were done in a short period of time. Next slide. So again, going back to the studies, again, this was another study showing that GHRPs absolutely improve our spatial learning and memory. Here was some other things that were shown by this study. It showed that we actually can increase the density of the neurons in the brain that is caused by Alzheimer's disease. We can protect some of these synapses from hypoxia, the loss of oxygen. We can also improve the apoptosis in the neurons and just the overall proliferation of the cells in the hippocampus. And again, we're trying. The GHRPs are shown to be have an anti-inflammatory effect on the inflammation caused by the amyloid beta plaques, which are the plaques in the brain that are the root cause of Alzheimer's disease. Next slide. So we know that if it'll come on up, there we go. We know that again, the effect of Alzheimer's disease is on the hippocampus, and we get this decreased hippocampal neurogenesis in Alzheimer's disease, which we believe is the main reason for the cognitive decline. And this was basically a slide from a study in 2019 to kind of show exactly what we're doing here with the GHRPs. And again, we're the main receptor that we're stimulating here, the GHSR, the growth hormone secretagogue receptor, is increasing the JAK2, STAT3, ERKs to get down to actually cause improvement in the SGZ cells, which is the subgranular zone cells. And by doing this, you're actually causing adult hippocampal neurogenesis, which is the opposite of what Alzheimer's disease is. So you're actually trying to keep that hippocampus healthy and functional. You can see how here there's some anti-ghrelin antibody, which is basically the anti-GHRP antibody, and it will stop this positive effect. And then also GHRPs will stimulate the cyclin A and the CDK2. You can see that over to the left, which is actually, whenever it does that, it's causing cell cycle progression from the G1 over to the S cycle, which is basically has to do with our DNA. It's promoting proper DNA packaging and replenishing. So, this was just a slide to actually show what the GHRPs are actually doing. Next slide. So amyloid beta plaques, they actually disturb the action of the neurotropic factors and the neurotransmitters on the receptors on the brain. And when this happens, we get synaptic loss and the dendritic degeneration. Again, these are all the brain cells that are so important, our learning and our speech patterns and those sorts of things. And this also leads to decreased synaptic plasticity. You can kind of see all this over in that right box, what's happening there. That's kind of a blown up version of the nerve cell. And it lowers it actually lowers the LTP and increases the LTD, which is the opposite of what we want. But this slide is just to show that how ghrelin actually, or the GHRPs, enhance actually synaptic density. So, on one hand, we've got Alzheimer's disease, which is trying to lower the synaptic density. It also restores the poor synaptic plasticity. We've got Alzheimer's trying to worsen the plasticity, and it alleviates a lot of this amyloid beta induced synaptic generation. Again, it's reversing all of these negative effects of Alzheimer's disease. So, and that was the basics of what we were trying to basically show with this overall lecture. Again, we in our practice, we frequently use the RHGHRPs, and we talk about so much more than dementia as to why we use these products in our practice. But this is just one more thing to really kind of hammer home how you can actually treat true disease processes with these peptides. So many of the times we're just promoting wellness, and I think that's great. The whole point of this lecture is still to go back to the fact that the biggest way to hit Alzheimer's is just don't get there. And trying to prevent it and trying to stay healthy. And we know that in addition to our weight and our blood sugar control and hormones, and we can exercise more appropriately, we can sleep better. I'm just trying to really hammer home the point of why this disease can be possibly avoided by some of our patients with proper risk modifications.
When my grandmother, she got Alzheimer's, it was the frustration that they feel when they're wanting to communicate, but it's not coming out. What I observed was they go through a big frustration period, which almost feels like anger.
Oh, I think that's absolutely right. Because, one of the things that we really treat a lot of in our behavioral unit or in our secure unit is behaviors. And I think there's a phase where a lot of these patients still are mentally somewhat there, but their mouth doesn't work with their brain, and they simply can't. They know what's going on. I do. And that's the saddest part, I think, is when they know what's going on and they just can't really verbalize it. They can't get out what they want. That phase can be shorter or longer for all patients. Sometimes it's fairly quick. Sometimes it can be months to years. As I always try to tell my patients and families is that unfortunately at the moment, the endpoint is the same for all of our Alzheimer's patients once they have it. It's just how long does it take to get there? And the medications, the traditional medications that are out there right now, they're just trying to push the endpoint out a bit. If Steve was originally going to become fully demented in 2 years, maybe we can push it out to 2.5 years or 3 years. It's not, hey, this is how we're going to cure this, which is the really sad part. And I really believe, and I think if someone were to listen to all these lectures that are going to happen about peptides on Saturday, there's really alternative ways to treat this. I'm not trying to say they're perfect, but I think they give patients and their families a whole lot more hope than what we have out there right now. The biggest issue is just it's not as widely accepted as your Namendas and Ariceps are, which I can just tell you in my own, and this is just my opinion, they just don't do much. I've got, at some point we just stop it because it's like, well, they're demented now. What's the point of continuing the Aricept and Namenda? And did it help? I mean, how do you really know what it did? Did it push it off a month? Did it push it off 6 months, a year, 2 years? I mean, how do you really know? With your loved ones? But horrible disease to watch, horrible disease to treat for the providers. I wouldn't wish it on anyone.
I have two sets of questions. I have the questions that the caretaker, the family members, they're totally unprepared with how to help manage this. And then the other set of questions I have are, this is in the back of everyone's mind. Am I at risk? And what do I need? If I'm really convicted, what would I start doing to preempt it? And I think that the conversation around these peptides, the conversations that we have all the time, are heading right there.
Yeah. And so I talk about the simplest things, like when someone comes in and says, I just want to lower my risk of dementia, my aunt had it and I'm scared to death of it. And what can I do? And especially, let's talk about females for a second. Estrogen deficiency, huge risk factor for dementia. So your menopausal women that are not replacing their hormones properly, estrogen deficiency is a huge risk factor. And it's a very important thing to do. Of course, bioidentical estrogen. Okay, everybody. We want to make sure and stick that in there. We don't want animal-based estrogens. That raises your risk of cancer, strokes, and heart attacks. But, it can start there, just proper hormone replacement. But it takes it so much further. You get the hormones right. And And by that, then you get your metabolism better. And hopefully then you feel better. And hopefully then you want to work out a little bit better. And hopefully you stay away from maybe some of those highly inflammatory foods and processed foods. And oh, hey, you know what? I sleep like crap. Okay, let's work on that for a little while. Let's monitor it. Like I tell my patients, let's spend a few bucks and get some form of an objective sleep monitoring device, whether that's an Apple Watch or an Oura Ring or a Fitbit. Just something that we can actually look at August compared to June and see how you slept. Because, you know, some of my patients come in, well, I think I'm sleeping better. Well, what does that mean? I mean, how do you really know unless you really monitor it? And we have such great monitoring devices today. Sleep's really important. And now, like I said, with some of these onsets of these tests that are coming, especially the one that we're so excited about, the Cytox, we're going to have access to in the next 2 or 3 months, which is going to be brand new to the United States and is going to be under $1,000 test to give us those real risk factors. I think is going to be vital because, you know, some patients like to take the attitude of just the ostrich and stick your head in the sand. This one will bite. Most disease will bite you in the butt with that attitude, but this one will really bite you in the butt with that attitude. You know, you at least want to go down swinging, I guess is what I would say when it comes to dementia. Put yourself, no one can guarantee if you do everything right that you're still going to avoid it. But it sure does put the odds more in your favor because like we've already said, this is a rough disease on the patient. It's a rougher disease on the loved ones, in my opinion. And I can't tell you how many discussions I've had in my life about having to place their loved one in a facility because, you know, family members, many of the times they want to keep them home as long as they can, but there becomes a point where that's not realistic any longer. And otherwise, and typically it's a spouse many times, or it's a child. They're trying to take care of their spouse or their mother or father, and they end up just taking themselves down with them. I mean, I've seen many spouses, I believe, died an early death by trying to take care of, to the end, their loved ones. Mm-hmm. And that's many times where I actually will sometimes make the recommendation that we place them in a facility so that their time with them is a little more quality and not spent, you know, without sleep and those sorts of things.
I found that I dealt with depression because it is a very frustrating disease. And here's this loved one that's angry at you, that's resistant, that's obnoxious, and you can't help but have this tension arise in you, and then you feel bad that you got upset because they can't help it, and this endless cycle that really messes with you. And if you don't have support, and if you don't have are prepared to handle this is detrimental to your health as well.
Yeah, no doubt. And you know, maybe just asking the same question, you know, 15 times in 20 minutes. And, you know, it's very common. Everyone gets frustrated by it and then they get mad at themselves, but it's human nature. I mean, you can tell yourself 1,000 times that it's not their fault, but it still doesn't change the frustration that's involved with it. And, you know, in addition to that, the financial implications of dementia, you know, there's so many families that don't have the resources and they're trying to find sitters. And, you know, because so many, if this is your parent, most likely you still have to work and you're trying to figure out, how do I make sure mom or dad doesn't burn the house down while I'm at work or fall and break something on themselves? I mean, you know, fall and break their hip or something. How would I know? And, you know, it's just such a tough disease. And that's why ultimately for many, it comes to placing them in a facility, and no one likes that thought, but many times it becomes necessary. It actually for the safety of the patient, because, you know, as I try to tell my families, well, the staff isn't going to get so frustrated by this because they're coming in working 8 to 5 and they're used to it. And it's not their loved one. They're going to take good care of them. Most facilities, I truly believe, take good care of these people. And, you know, you can come in and just be the family member and visit with them for a few hours and not get so frustrated and upset and like I said, you're getting ready for bed and they're getting wound up because they're sundowning. I mean, you know, it can be wild at the memory care unit. I'm not lying when I say that. It can be the wild, wild west in there. But these are people that take care of them. It's their job and they're rested, and, you know, it's just what they're getting paid to do. So it's a much better experience. But yeah, the financial, this can, I read something the other day about the impact of cancer on a family and how expensive having cancer can be for a family member. And I would think that dementia has to be just as expensive, if not even more than cancer. It's just never ending, having to have around the clock care as they worsen. And just like you said, and that's what I meant is you'll have a spouse that starts out pretty healthy when their spouse gets dementia. And by the time the dementia patient passes away, they're a mess. I mean, it's taken years off their life. And again, just a horrible disease.
One thing I found really helpful is as it worsens, to have a very predictable schedule, a calm environment, a regular, on the dot, as far as like, here's some water to keep them hydrated. It really improved the quality of the life of the person that I worked with that had this condition. We go through a life that we're okay with all these unknowns and unexpecteds. But if you're having a problem with communication going through your brain, unexpected things can really, really aggravate it.
Yeah, you have to keep a tight schedule with your dementia patients. They have to eat at the same time, and that's why, like in facilities, breakfast is at 7:45, lunch is at 12 o'clock, and they know that everything stays on a particular schedule. Let's say mom or dad or brother, sister who has Alzheimer's, and you have to take them to the hospital for something. Why does it get so much worse? You've taken them out of their schedule. You've changed their environment. Like when I get dementia patients into my rehab centers, the first thing we try to tell them to do is to bring pictures or something from home that can just give them a slight bit of orientation, because maybe at home dad was oriented times two. At least he knew, who he was, who his loved ones were, and maybe where he was. And then you put them into a facility, and I always try to warn the family members of this. Look, the first 2 or 3 weeks is going to be rough. They're going to get disoriented. They're going to act out. And here's some things we're going to do to try to minimize that, and just keep reassuring them. And we minimize that by bringing in some things that they can still recognize, whether it's family's pictures or a painting or just anything that they used to be, that they could have bonded with to really help in that scenario. But yeah, I totally agree. Keeping a schedule is really, really important.
Well, one thing that really became apparent to me is these long-term memories, they stayed longer. But like when you asked a question, like for example, this gentleman started to forget how to swallow.
Mm-hmm.
He would just hold the water there in his mouth, and then it would start to drain out. And if you said, "Hey, swallow," it would go in,
mm-hmm.
but it wouldn't come out. I mean, the brain wouldn't translate it in, "Oh, I need to swallow." So what I would do is like, "What's your name?" And then he would swallow to tell me his name.
I gotcha. That's a good one.
Yeah. And so you have to understand little workarounds like that.
Yeah, and again, going back to what I said at the beginning, is a lot of the decline of the Alzheimer's patient is lack of ability to take in proper nutrition and hydration. Whether they just lose the want to eat, or whether they lose the function, the ability to actually swallow properly. We call it oral pharyngeal dysphagia. They just can't make the mouth and the throat work together. Something that to us is just not even something we think about, but they lose that ability because of that hippocampal dysfunction. The one thing I do try to educate my patients on is when you do get a loved one that's in that state, it's a painless thing, not eating. And because so many family members, they struggle with, should I put a feeding tube into my loved one? And certainly if that's what a family member decides, I'm not going to ridicule them for that, but I never recommend a feeding tube, because when we get to that point, all we're doing is pushing off a point in time that the quality of life, unfortunately, has left. And I think you and I can agree for sure on this one that it's all about quality. It's not necessarily about quantity. We want both. We want quality and quantity. That's great. But, I always tell patients if I lived to 90, but my last 20 years are horrific, I'd take maybe living to 82 and it'd all be good. And so that's what a lot of family members struggle with these dementia patients. Should I put a feeding tube in? Should I not put a feeding tube in? Luckily, most of my families get it, but every now and then they will stick a feeding tube in these patients, and they can keep them alive for years like this, sometimes even in a vegetative state, and it just makes me cringe. But, that's a familial decision. I want to make this one point real quick, and I'll shut up, but make your wishes known to your loved ones. I cannot tell you how many times I sit down with a family and I'm like, what would dad have wanted? I have no idea. We never talked about it. It was taboo. We didn't talk about death or if I'm in this situation. Well, shame on everyone. You need to let your feelings and your wants be known, because if you don't do that, then your kids or your spouse have the guilt of making these decisions for you instead of, just telling them what you wanted done. And that's a lot of guilt to carry around for some family members. Some family members understand it and get it, but a lot of these family members will carry around this guilt for a really long period of time.
If there was ever a reason to convince you to up your game as far as addressing the inflammatory aspects that your body is dealing with, if it was just so that your loved ones don't have to manage you in a memory care unit, then it would make a lot of sense to start taking care of yourself and addressing these things. And so if someone wanted to reach out to you and go, okay, I listened to that conversation, Dr. Kris, and you convinced me I don't want to do that, where would we begin? How do we connect with you? What would we do? What would that look like?
Yeah, the easiest way is just call us, 817-599-9902, or go to our website, theresurgeclinic.com. You see it at the bottom of the screen. You can also email me at drdrkris, Kris, at theresurgeclinic.com. Any of those ways work, but I'll be honest with you, calling is the quickest way. If you email me, I'll get to it, but it may take a day or two. My staff will answer anytime you call. That's the easiest way to get a hold of us.
Yeah, so be prepared to have a conversation about eating better, sleeping better, getting a little exercise. Let's consider the hormones, and then let's also consider maybe some peptides. But again, these conversations are intended as educational, and you should always consult your physician before you change anything based on these conversations. If your doctor maybe is open to it and you would like for them to reach out, Dr. Kris is very helpful with that as well. And maybe you've been considering changing doctors. Well, this would be a good time to re-energize your efforts and connect with Dr. Kris at the Resurge Clinic. Dr. Kris, that was really educational, and I think it's something that every one of us is going to have to, if we're not dealing with it now, it's sure on the agenda of your life in one way or another. And it would be smart to start to get your loved ones to make the changes they need. And you should consider those as well.
Absolutely. Couldn't agree more. Well said.
All right, folks. So that was another excellent episode. I could ask you questions about this. Maybe we should consider a conversation where we talk about if you're managing someone or if you have a loved one that's suffering from this, what would be some things that you could be doing to help improve your health, your sanity, and
absolutely. That'd be a great topic, actually.
Okay. All right, Dr. Kris, this was excellent. Thank you for your time. You guys be sure to stay tuned. We'll be here next week. And thanks. That was excellent.
Thanks, Dave.
That's a wrap.